Hey students, we're back. This is Barbara Garcia talking a little bit about the disorders of endocrine function. And remember, if you need a review of endocrine function, I suggest that you look over chapter 39. All right, so some of the basic concepts, right, of the endocrine disorders, right, include hypersecretion or hyperfunction and hyposecretion and hypofunction, and then non-responsiveness by target cells, which basically leads to a type of hypofunction, right? So hypersecretion is usually going to be seen by a tumor that secretes a particular hormone. So you might see a pituitary adenoma that secretes prolactin, and a prolactin secreting adenoma is going to produce probably breast milk in a female. In a pituitary adenoma that secretes growth hormone, you might see something like gigantism. So we'll talk about some of those in a little bit, right? So some autoimmune disorders can mimic the function of hormones, and so you'll see what appears to be symptoms of a hypersecretion, and then of course excessive stimulation by the gland by the trophic signal, so basically the signal before it. Hyposecretion is a failure or congenital absence of glandular tissue, right? Autoimmune destruction or surgical removal of the gland, which one example that happens very often is when they remove the thyroid gland, which of course then they have to supplement all of the thyroid hormones. They also remove some of the parathyroid glands because they're obviously attached. It's very, very hard to keep parathyroids without the thyroid gland. So many times they will also have to supplement the parathyroid hormones, which control body fluid, right, and calcium in the blood. Hyporesponsiveness. So the target tissue is dysfunctional, right? So it's clinically similar to hyposecretion, but it means that the problem isn't that the gland isn't secreting it, is that the target tissues aren't understanding the message. So that could be that there is a receptor problem, like there might be an insulin resistance. All right, so you can see their hypofunction. Some of the ways that you can get some of the etiology behind hypofunction, right? Trauma, radiation, ischemia to the gland. And then hyperfunction, right? Microadenoma, adenoma, and adenocarcinoma. And then in the different levels, right? So the excessive trophic hormones might cause, right, secreting tumors. Autoimmune stimulation can also cause hyperfunction, and excessive hormone administration you might see also as well, right? So if you are taking too much medication, for example, I have a thyroid problem, and if I were to take too much medication, I'm going to have symptoms of hyperfunction. Okay, so one time I took too much of my thyroid hormone, and I was basically instead of hypothyroidism, I have hyperthyroidism. Right, so some other things with hypofunction is you can have, sudden withdrawal of exogenous hormones, tissue resistance or downregulation of receptors, like I mentioned before, or receptor defects. All right, so some of those functions, right? So how can these endocrine disorders come about? Well, some of them could be congenital. They're a inborn defect, right? Most of them are genetic, if not all of them, because remember, if you're talking about receptors or hormones, the majority of hormones are derived from proteins, and all of the receptors are proteins. So that could be one of the reasons, right, that you're going to have an endocrine disorder. That this is a, congenital could be causes excessive production of hormone precursors. That could be the case as well. Autoimmune, it involves a genetic predisposition and an environmental trigger, and then antibodies are made against antigens on self-tissue cells. So it's quite common to have, for example, Hashimoto's thyroiditis, or Graves' disease even, right? Those are both autoimmune. And then neoplastic, right? So you have hormones being produced by abnormal tissue types, right? Because of malignancies. Right, so some of these functional disorders can also be caused by non-endocrine disease, such as chronic liver failure and chronic renal failure or heart failure. So if you have failure of the organs that are regulatory, then you might also have functional disorders. And then tissue resistance, right? The target tissue is now not responding to the hormone anymore. Again, mostly involving a damaged or lack of, right, a downregulation of the receptor. All right, so it could also be iatrogenic, right? So iatrogenic means that it is induced by some type of medical treatment. Very commonly, chemotherapy, radiation therapy, or surgical removal of glands can induce endocrine disorders. Treatment for endocrine hyperfunction involves removal or destruction of glandular tissue, which can then result in chronic hypofunction, right? So then you might require replacement of those hormones for life. All right, so endocrine disorders. So one of the way we classify them is primary. That means the intrinsic malfunction of the hormone producing gland, or it could be secondary, and abnormal pituitary secretion of trophic signals, right? So since the clinical manifestations are similar, lab results can help us distinguish between whether it is primary, right, so some malfunction, or secondary by trophic signals being abnormal. Right, so in primary, the gland fails, right? So you have inadequate hormone produced, low levels of circulating hormone, but blood levels of the corresponding trophic pituitary hormones are very elevated. So just to use myself as an example, I have hypothyroidism, and in a hypothyroidism, I have very low levels of T3 and T4. So if you remember, go back. If you don't remember why it's T3 and T4, these are your thyroid hormones, and I have a very low level of my thyroid hormones. But instead, I have very high levels of TSH, thyroid stimulating hormone, which is being released by the pituitary gland. So I have a primary endocrine disorder, of which I have to take levothyroxine, right, which is the replacement for your thyroid hormone when thyroids are not working properly. So remember when I told you that I was taking too much medication? So remember that the medication works very similar to the hormone. So it is going to negatively inhibit the production of TSH from the pituitary gland. So when I was taking too much of it, TSH was very low. I mean, I have a lab report that says TSH, and right next to it, it says undetectable. So my doctor was like, yeah, you might be taking a little bit too much thyroid hormone. We're going to need to cut you down a little bit. And then, you know, most of my life, I've had my TSH levels be very high. So if I don't take my medication, my TSH levels are very, very high. So there's definitely a glandular failure. That's just an example of, you know, what can happen, right? In secondary failure, right, the pituitary gland fails to release a trophic hormone, right? Then, so that would be easy to find out. So are we secreting TSH, or are we, you know, and therefore there is TSH being secreted but no thyroid hormone? Then that would then indicate that's primary, right? Because that means that the gland where the target tissue is, it is either receiving the message and not replying, or not receiving the message. That one's a little bit, the target tissue, whether or not it has receptors, it's a little bit more difficult. It's going to take something else for us to know that. But for example, my mother also has a thyroid problem. However, hers is secondary. She is actually not releasing the trophic hormone from her brain. So they told her her thyroid problem is in her brain. So she is not releasing the TSH at all. So how can your gland release thyroid hormone if it's not being stimulated to release thyroid hormone, right? So her problem is then that she is not secreting any TSH, the trophic hormone. So then both of them are very low. So a lab report would help you distinguish that, right? So some growth hormone disorders, like I mentioned before, it is produced in the anterior pituitary. Remember that growth is going to be basically regulated by, it's, you know, everywhere in your body. So that is going to have growth receptors. One of the main places that's going to have growth receptors, especially in children that are growing, is the epiphyseal growth plate, right? So that's very, very important. But another target of your growth hormone is also going to be the liver, because the liver then secretes growth factors. So you have to remember that. All right, so growth hormone is produced in the anterior pituitary, right? Is regulated by the hypothalamic release of growth hormone releasing hormone and inhibiting, which is somatostatin factors, right? The primary target of the organ is the liver, because again, that's where we go to release growth factors. And why might we do that? Again, that's something you're going to have to review back in chapter 39 or in your physiology book. The reason we do that is because growth hormone has a very short half-life. And so growth factors have a much longer half-life, right? And so what does the growth hormone do? It increases lean body mass. So one of the things that if you want to grow muscle, then you're going to have growth hormone, okay? So if you're deficient in growth hormone, then growing muscle is going to be very, very hard, if not impossible. So you want to, if you want to grow muscle, then you have to be very aware of how growth hormone functions in your body. Basically, it is released when you sleep, right? So if you are depriving yourself of sleep, then you're going to have a decrease in the effects of growth hormone, right? It reduces fat mass and induces the liver to release glucose under conditions of hypoglycemia. All right, the etiology of many growth hormone deficiencies involve a decrease in growth hormone secretion or defective growth hormone action. So some sort of structurally abnormal growth hormone or a defective receptor. And then defective IGF-1, which is somatomedin, which is what's released by the liver. That's the insulin-like growth factor. All right, so then pathogenesis, you know, may or may not be related to tumors. So it could be idiopathic. It could be related to radiation or trauma, right? So growth hormone deficiencies are most clinically relevant in children because clearly if children are not receiving growth hormone, then they are not going to reach their maximum potential height. So could be associated with birth history of prolonged labor or breech delivery, some congenital malformation or chromosomal anomaly, nystagmus, retinal abnormalities, midline or midfacial abnormalities such as cleft lip or cleft palate. So another would be like a midline brain tumor, which could affect the pituitary gland. Radiation therapy for brain tumors or leukemia or trauma to the skull or sella turcica, which is, you know, where the pituitary gland is housed, right? So clinical manifestations of hormone deficiency include hypoglycemia, so growth below the 3rd percentile, which definitely indicates a growth hormone, a lack of growth hormone, right? Dental eruption, delay, irregular setting of permanent teeth, thin hair, poor nail growth, greater fat mass, decreased muscle mass, and delayed bone formation and delayed puberty, right? So insulin, arginine, levodopa, and clonidine are agents that stimulate growth hormone release in children. So if you can administer these, right, and decrease growth hormone levels, and then deficient growth hormone release in response to the above listed agents. So the treatment is hormonal replacement therapy with growth hormone. So stimulation of linear growth in children whose bones have not fused. So for example, if you have a child who is looking to be below or as is in the bottom third in height, they might offer you growth hormone as a solution. In this country, remember, we have significant medical care where there's a lot of progression of the child's growth listed in medical documents. So, you know, it's reported in medical documents. So it's very unlikely that a pituitary dwarf like Napoleon was reported to be is going to happen very much in this country, so that a child will not reach their full potential height, because again, we just monitor things in in this country and in other countries of significant wealth. They monitor these things. Now in other countries where medical care is not as robust as it is here, then you might see more pituitary dwarfism in children, or other endocrine abnormalities that were not tested for because the symptoms that the child showed didn't seem to be relevant, right? And or not understood by maybe the tribe, or the elders in the group may not have understood what was going on with the child. So there's this really great special on TLC that has to do with growth disorders, and there are 3 children that are mentioned, and one of them is from Brazil. She's from a very rural part of Brazil, and she has like an endocrine disorder. So she's a cretin, which is what happens when you don't have any thyroid hormone. So that's an example of something that can happen to a child in another country that is very unlikely to happen here. So even that has nothing to do with growth hormone, but she did end up being very, very short stature and very much intellectually disabled due to a missing hormone, which is simple solution if there was good medical care. All right, so clinical manifestations in adults, you might see diminished lean body mass, hypercholesterolemia, decreased bone density, and so they just give them growth hormone replacement therapy. Right, so which of the following may be associated with growth hormone deficiency in infants? Right, so goiter, myxedema, exophthalmos, those all have to do with endocrine problems related to thyroid, and so A, hypoglycemia is going to be your best answer. All right, so where you can have growth hormone deficiencies that can lead to a child that turns into an adult with pituitary dwarfism. And I want you to remember the difference between pituitary dwarfism, right, and achondroplastic dwarfism, right? So a pituitary dwarf is somebody who just doesn't have growth hormone. Okay, have a hyposecretion of growth hormone. A person who is achondroplastic dwarf has a problem in their epiphyseal growth plate. So they will actually have very short, long bones, right? So the long bones of the arms and the legs are very, very short, of the fingers are very, very short, but their trunks, their, head and body, right? Their trunk is going to be normal size. And so that's an achondroplastic dwarf that causes a little bit more of difficulty with normal functioning. So a lot of achondroplastic dwarfs have to have lots of surgeries because of the way things grow abnormally. A pituitary dwarf is really just somebody who is, take a human and decrease their size by 50%, or 40%. And that's basically what they are. So they're very proportional. Their arms and legs are very proportional. They're just short in stature. All right, so then growth hormone excess then is going to be, uncontrolled production, maybe a benign tumor of the pituitary. We call those pituitary adenomas, right? Stimulates the liver to produce IGF-1, right? It causes upregulation of growth of soft and bony tissue. So it may cause a persistent hyperglycemia and increased insulin production, right? Because growth hormone is also called diabetogenic hormone. It's a diabetogenic hormone, right? And then if the child is still has open growth plates, then this child would be called a pituitary giant, right? Or what we call acromegalic gigantism. That's the new, more accepted name, right? So they are also pituitary giantism is what it says here. Occurs, right, if the epiphyseal plates have not growth. So you might see accelerated growth if it's greater than the 95th percentile on a pediatric growth chart. Also very rapid growth. So you might see very rapid growth in a child. So maybe in 3 months, they're growing over 6 inches in height, So if left untreated, they may grow very, very tall, 7 to 8 feet in height, with increase of cardiomegaly and heart failure. In an adult whose epiphyseal growth plates have closed, we call it acromegaly. And acromegaly, so by itself without the word gigantism, so acromegaly has certain symptoms as well, because your nose, your jaw, your fingers in thickness more so than in length, they continue growing throughout your life. Okay, so you will see some very minor changes, mostly in the face. And so a lot of times acromegaly is diagnosed by a doctor who sees some symptoms that are bizarre, that kind of piqued his interest, and then would ask for a picture of you from 10 years ago, and they could see the changes in a 10-year span. All right, so clinical manifestations, right? Increased ring or shoe size, enlargement of the frontal sinuses, right? Causing a very prominent brow, right? Growth of mandible leads to progressive underbite, called prognathism, right? Coarse facial features. You may see a lot of skin tags, which is related to the hyperglycemia. Increased size of internal organs, deepening voice, and enlarged tongue. Right, so you could see here in this woman how in an earlier picture she has more feminine features, and notice how the nose has grown, the brow has grown, the jaw has grown over the course of maybe 20 or 30 years. All right, growth hormone excess can be diagnosed with high insulin-like growth factor 1 and elevated growth hormone that is not suppressed by the administration of oral glucose. And then so surgical removal of the tumor, or counteracting the effects of the excess growth hormone, we call that with octreotide, which is a synthetic somatostatin. Radiation may also be used, but this is usually good enough, the octreotide. Right, so growth, thyroid hormone disorders, right? So remember, triiodothyronine T3 and thyroxine T4 are regulated by thyroid stimulating hormone that is secreted from the anterior pituitary. So the thyroid hormones are produced in the follicular cells of the thyroid. So make sure you go and look at a picture of what that looks like, so that you remember, with the colloid, the pink clear things with the very cuboidal cells around it. I love looking at the thyroid underneath the hormone. So remember, thyroid hormone is a regulator of metabolism, right? So it promotes the production of ATP. So if you don't have thyroid hormone. If you don't have thyroid hormone, then what's going to happen is you're not going to be able to have normal growth and development of tissues, because that requires a lot of ATP. Right, so hypothyroidism, right, may be congenital or acquired, right? If it's congenital, which means you're born without it, that actually is pretty significant and pretty severe. The majority of these disorders are primary. They are due to intrinsic thyroid gland dysfunction, right? And then congenital hypothyroidism, called cretinism, like the example that I gave you previously, is typically due to thyroid dysgenesis, which basically means that the thyroid gland never developed. Secondary can be due to defects in TSH production, usually associated with some head or brain conditions. Remember those midline tumors or midline problems, because that means that the pituitary gland didn't develop. All right, so most common cause of acquired hypothyroidism is lymphocytic thyroiditis. It is a Hashimoto or autoimmune thyroiditis. Right? Irradiation of the thyroid gland can also lead to hypothyroidism, surgical removal of the thyroid tissue, or iodine deficiency, which is required for T3 and T4 formation. Obviously, the 3 and the 4, if you haven't already looked it up, is the number of iodines that are attached to your hormone. Right? So if you have very low iodine, then you're not going to be able to form functional thyroid hormone. All right, so remember how we have this obsession now with sea salt, which is great. Sea salt is excellent. However, back in like 1900, they tried to figure out where we can put iodine so that we don't have a problem in this country. So some public health people kind of came together with some doctors, and they figured that we can put it in salt. That's why salt is iodized. And so we're now with this really cool, like, let's be all organic and let's use sea salt. That's great and all, but now you're excluding the iodine, which if you have a proper diet, you know, iodine is found in a bunch of other things. So, you know, proper vegetables and stuff like that. So if you have a good, well-balanced diet, you should have no problem finding and having enough thyroid hormone. However, enough iodine to make thyroid hormone. However, you know, the diets in the United States are not exactly very well balanced. So, I worry a little bit about this new trend of sea salt, right? You'll see that some of the countries that have the highest, rate of goiters due to lack of iodine are countries that are near the Dead Sea, where basically they make sea salt, and that's how they get salt, is from the ocean and dehydrated, or from the Dead Sea. So a lot of countries near and around India, just to kind of give you an idea of where that is, right? So you'll see that India, because India has such a huge population of people, they have a lot of goiter, right? Lots and lots of goiter, right? So if you don't have iodine, you don't have T3, T4, right? So then you increase TSH, causes the thyroid cells to secrete large amounts of thyroglobulin, and then thyroglobulin leads to goiter. So you can see there a picture of a goiter, right? So hypothyroidism, right? So we have a very good screening for newborns. Again, if we don't screen newborns for congenital hypothyroidism, then you would have a bunch of babies that with a simple pill could have, you know, been fine, but all of a sudden have intellectual disability and don't grow. That's not going to happen in this country. So we, you know, routinely screen newborns for these things, so that if that is the case, then we are going to treat it, right? They have a dull appearance, thick protuberant tongue, and thick lips, right? Prolonged neonatal jaundice, poor muscle tone, umbilical hernia, bradycardia, mottled extremities, hoarse cry, mental retardation unless treated early, right? In children and adults, you'll see a decreased basal metabolic rate, weakness, lethargy, cold intolerance, decreased appetite. You'll see bradycardia, a narrowed pulse pressure, which, remember, the pulse pressure is the systolic minus diastolic, so they might be something like, you know, 120 over, you know, 90, so that the pulse pressure is only 30, right? And then mild to moderate weight gain. Obviously, if your basal metabolic rate is very low, then you eat like we eat in the United States, where you have, you know, a salad that has 1,200 calories, then you're going to have a lot, you're going to see some weight gain. All right. So elevated serum cholesterol and triglycerides, you might see enlarged thyroid, dry skin, constipation, depression, difficulties with concentration and memories, a loss of eyebrow. I know that sounds weird, but the end of the eyebrow, they'll have very sparse hair at the end of the eyebrows, and then a menstrual irregularity. Right, so obviously diagnosis is going to be based on elevated TSH, right, which indicates a thyroid hypoactivity, and secondarily you would have a low TSH, so depending if it's a primary or secondary, and then both will lead to low levels of T3 and T4. That may not necessarily occur until later in the disease course. Goal is to return to the euthyroid or normal state, right? And then you're going to see oral levothyroxine, right? And then the resolution of symptoms occurs over weeks. So you must progress quite slowly to get it back to that euthyroid stage. All right, mixed edema occurs in severe or prolonged hypothyroidism. You might see what we call a non-pitting edema. It's generalized. You'll see it often pre-tibial. Mixed edema is very common. So, and you know, your tibial bone on your calf, if you have that in the lower leg, and you press, and that's that non-pitting edema, right? And then you'll see it, you press and you don't get the edema that sticks in and stays in. All right, the decreased level of consciousness, right? You might see hypotension, hypothermia, history of a precipitating event, trauma, sepsis, or certain drugs. And then progress to myxedema, coma, which is a life-threatening situation if treatment is not received. So you can see there's some myxedema, right? Hyperthyroidism, right? So it's hyperfunction of the thyroid, right? With increased synthesis and secretion of T3 and T4, like you would have in Graves' disease. This could be thyroid destruction with release of preformed T3 and T4, like you might see in Hashimoto's thyroiditis, right? Primary is Graves' disease, autoimmune, tumor-related, or inflammatory in nature, right? Where you're going to have TSH receptor antibodies being the main cause of that primary hyperthyroidism. And then you'll have secondary, which is stimulation of the TSH receptors by TSH. So you have a hypersecretion of TSH from your pituitary gland. Right, so etiology and pathogenesis, most common is autoantibodies bind and stimulate TSH receptors, leading to what we call a toxic goiter, called also is what we see in Graves' disease. Right, so associated with certain genetic markers, it is autoimmune. You have thyromegaly, right? So you have thyroid gland increases in size. And exophthalmos is a very, very important word, right? Means that your eyes bulge out. Okay, so this is very, very common with Graves' disease. And one of the only times that you'll see exophthalmos is in people with Graves' disease. Okay, so keep that in mind. That is a question that you will see at some point in the next 2 years. Immune mediated, so it may not resolve with treatment. Right, you have a widening of the palpebral fissure, right, resulting in an exposed sclera. You might see lid lag, vision changes, and photophobia. Right, so you could see that kind of drooping, and then exophthalmos. All right, so clinical manifestations, you might see changes in behavior, insomnia, restlessness, tremor, irritability, palpitations. It's basically the opposite of hypothyroidism, right? Heat intolerance, diaphoresis, so lots of sweating, diarrhea. So in hypothyroidism, you have constipation. In hyperthyroidism, you have diarrhea. So inability to concentrate, which interferes with work performance, and you might see an enlarged thyroid gland. Right, so it also leads to increased basal metabolic rate, leading to weight loss through appetite and dietary increase. You might see amenorrhea or scant menses. All right, so diagnosis, TSH levels, right, are going to help in differentiating primary from secondary hypothyroidism, right? So just like hypothyroidism, right? Elevated T3 and T4 is used to confirm, right? And then a 24-hour radioactive iodine uptake study can confirm the diagnosis of Graves' disease and exclude the presence of thyroid neoplasms. All right, so some of the treatments of hyperthyroidism is beta blockers, to block acute symptoms, anti-thyroid drugs, thioamides, which are propylthiouracil, which is very, very common, and then a methimazole. And then radioactive iodine treatment also is going to be used to destroy part of the thyroid in Graves' disease, and surgical removal of the thyroid gland, typically reserved for tumors, and pituitary adenomas, again in the pituitary gland, they are treated surgically. Remember, pituitary adenoma is a benign tumor. So thyroid storm is something that can happen with people, especially with Graves' disease, but it can also happen without diagnosed Graves' disease. It's a life-threatening thyrotoxicosis that occurs when excessive amounts of thyroid hormones are released into circulation. You might see clinical manifestations including elevated temperature, tachycardia, arrhythmia, and congestive heart failure, extreme restlessness, agitation, psychosis, and it could be even, stress or gland manipulation be the precipitating event for the thyroid storm. Right? So you have to have aggressive treatment to achieve a metabolic balance, and antithyroid drugs are given, followed by iodine administration. And then beta blockers to alleviate any cardiac symptoms, antipyretic therapy fluid replacements, surgical removal of the tumor, and it is fatal if it is not treated. So this is something that you might definitely see in an emergency room. All right, adrenocortical hormone disorders, right? That, remember, the adrenal cortex synthesizes three things: the glucocorticoids, which is cortisol, and cortisol is going to be released from the zona fasciculata. Remember that that's the second layer of your adrenal cortex. The first layer of your adrenal cortex is going to release mineralocorticoids, which are going to be aldosterone, which is regulated by the presence of angiotensin 2. Right? Remember the RAS system, RAAS. It's time to review it. Okay? And then that is called your zona glomerulosa. And then the zona reticularis is going to release your sex hormones, mostly testosterone. Testosterone can be converted into estrogen in your fat. So adrenocortical insufficiency, right? So hyposecretion due to disease of the adrenal cortex, idiopathic or autoimmune, and autoimmune can be Addison's disease. Right, so and then it might require surgical removal. Secondary is an inadequate secretion of ACTH, which is usually iatrogenic or related to some sort of corticosteroid therapy. Right, so if you have been receiving prednisone, which is cortisol basically, right, for the last 3 years to treat something else unrelated to your endocrine, but it could be autoimmune, very, very likely, you might have inhibited and downregulated the production of ACTH so much so that it is now going to shut off and not make any at all. One of the main reasons why, if you are taking prednisone, you can't just cut yourself off of prednisone. You need to slowly taper down the medication of prednisone in order for you to be able to see if your pituitary gland is secreting ACTH and that your adrenal cortex is secreting corticosteroids, right? Cortisol. So if it isn't, then you may need to stay on prednisone for life, right? And then hypothalamic malfunction or injury could be tertiary, right? So cortisol insufficiency is the most clinically relevant of the adrenocortical insufficiencies, right? You also may see congenital adrenal hyperplasia. It is rare, but it is due to a specific enzymatic defect in the biosynthesis of cortisol by the adrenals. It could cause severe and life-threatening symptoms. Overproduction of ACTH leads to hyperplasia of the adrenal glands and excessive androgen secretion. All right, so some clinical manifestations of adrenocortical insufficiency include anorexia, weight loss, salt wasting, right? Weakness, malaise. Remember, because if you have salt wasting, because if you do not have aldosterone, then you're not reabsorbing sodium from your distal convoluted tubule in your nephron, in your kidneys, right? So weakness, malaise, apathy, electrolyte disturbances, again, because you are not eliminating, not reabsorbing the right amount of sodium, not eliminating the right amount of potassium. You might see hyperpigmentation of the skin, hypoglycemia, and hyperkalemia. Diminished vascular tone, so reduced cardiac output, and inadequate circulation of blood volume, low blood pressure, and that could lead to cardiovascular collapse. Right, so diagnosis, this is all can happen if you were to be on prednisone and then completely shut yourself off prednisone because, you know, they don't want to take your patient, I'm assuming it's going to be the one that does that, and doesn't want to take their medication anymore. Right, so decreased plasma cortisol levels, right, ACTH is high, is primary, and ACTH is low is secondary, remember? So we have a ACTH provocation test that we can use. So serum cortisol levels increase following the stimulation if the adrenal cortex is normal, but if there's a failure to produce cortisol, it indicates a primary adrenal insufficiency, right? So obviously you can take a CT or MRI to evaluate the size of the adrenal gland. Treatment is replacing the absent or deficient hormones, right, in a manner that mimics the natural production, right? So 2/3 of the daily dose is given in the morning and 1/3 in the evening. So stressful situations like illness, injury, or surgery may require an increase, just like it would in your body, like increase in cortisol. Right, so Addisonian crisis or acute adrenal insufficiency, right, is a life-threatening condition caused by inadequate levels of glucocorticoids and mineralocorticoids, leading to circulatory collapse. May occur with acute withdrawals of corticosteroids due to periods of stress and trauma. So the treatment would be intravenous glucocorticoids and volume replacement. So question 2. A patient has a low cortisol level from autoimmune destruction of the adrenal gland. Which diagnosis will the, remember it's autoimmune, which diagnosis will the nurse observe documented on the chart? Pheochromocytoma, cretinism, Cushing syndrome, or Addison's disease? Right? So right now we were just talking about Addison's disease, so you know that that's the best answer. But now we want to make sure you know what the other ones of these are. I have a feeling that pheochromocytoma and Cushing syndrome we're going to address in just a minute. And then cretinism, remember, that is a congenital decrease of thyroid hormone. And, you know, nothing is done about it, which can lead to hypoglycemia, low growth, you know, protection, large enlargement of the jaw and lips, and mental retardation. Also, we prefer to call it intellectual disability. All right, so congenital adrenal hyperplasia or adrenogenital syndrome, you might have heard it called like that, or might see it called like that in different books, right? Is that you are lacking the enzyme for cortisol production due to a gene defect. Remember, there is a bunch of enzymes that are going to make your, remember, all of these hormones, by the way, majority of them, anything coming from your adrenal cortex are all hydrophobic. So aldosterone is hydrophobic, cortisol is hydrophobic, all of them are hydrophobic. Right, so elevated ACTH secretion leads to adrenal hypertrophy, overproduction of steroid precursors, which increase androgens. This can lead to masculinization, and you need to go and look at a chart that shows you the cholesterol-derived hormones. So just type in cholesterol-derived hormones, and so you could see all of the enzymes that are required for that. Right, so you could see precocious puberty in males as well. Life-threatening in the newborn, right, because of inadequate circulating cortisol. And so the treatment is with glucocorticoids. So you might see that virilization of the female, where the female is going to have a labia minora, that are sealed, and that has like what we would look like as a very underdeveloped penis. So basically they would be hermaphrodites. All right, hypercortisolism, right, we call that Cushing disease. Yes, so now you know. And there's also something called Cushing syndrome, right? So Cushing disease, right, is only used for pituitary hyperstimulation of the adrenal cortex, where the adrenal cortex is the one secreting excess cortisol. Cushing syndrome is a term used to describe any other reason for hypercortisolism. So if there is a, if you're using too much prednisone, again, because maybe the person has an autoimmune disorder, they're going to have Cushing syndrome. Basically, they're going to have all of the signs and symptoms of Cushing's, but it's obviously iatrogenic, right? So primary is the disease of the adrenal cortex. Secondary is hyperfunction of the anterior pituitary secreting cells. And then tertiary is hypothalamic dysfunction or injury, right? So microadenomas or adenomas can cause an increase in the production of pituitary ACTH, right? And so non-pituitary tumors can also cause ectopic ACTH production. And exogenous steroid use is the most common cause of Cushing syndrome in the United States. So if you use too much hydrocortisone. Right, so clinical manifestations that you'll see in hypercortisolism, again, also seen in people who are taking too much or hydrocortisone or prednisone, right? So the round face with flushed cheeks, we call that the moon face, right? We have weight gain with excess body fat, particularly in the abdomen and the thin extremities. And the reason we do that is because, remember, cortisol also does something called gluconeogenesis. So it's going to take proteins and it's going to convert them to glucose. So you're going to see hyperglycemia. And so where does all of this coming from? It's all coming from the muscle wasting. Okay, cervical fat pad, capillary fibrility, right? So the capillaries are very, very frail. Thin skin, right, with purple striae, particularly in the abdomen. So in other words, stretch marks. Ecchymosis over the abdomen, and then arms and thighs, right? You'll see on the skin, right? Darkening of the skin. A decreased muscle mass and muscle weakness, glucose intolerance, and hyperglycemia. So you could see there, very, very typical. So thinning extremities, right? You might see impaired wound healing, ecchymosis, thinning pubic and axillary hair in women, truncal obesity, moon face, hirsutism, so growth of hair, particularly in the chest and around the nipple in female, or in the face, mood swings as well, dorsal cervical fat pad, very common. All right, hypercortisolism, right? So you might see hypertension as the salt retaining activity of cortisol is increased, right? The demineralization of bone, so we lead to osteoporosis. You'll see increased androgen production in causing excessive hair loss, acne, menstrual irregularities, emotional lability, anxiety, irritability, and depression, right? So ACTH is measured, right? It is primary, again, if ACTH is low. Secondary if ACTH is high. Okay, so in hypercortisolism, you'll have high ACTH. It's the secondary, right? So plasma cortisol levels are increased. In the 24-hour urinary free cortisol levels, you can also be used to diagnose. And dexamethasone suppression test is going to help you distinguish between pituitary causes and other causes outside of the pituitary gland we call ectopic causes. Right, so based on the etiology, right, you're going to treat. So you also may have an exogenous dose reduction if it's because of too much drug use, transsphenoidal hypophysectomy, or laser ablation of the pituitary gland, right, if it's pituitary disease, right, unilateral adrenalectomy or radiation if it's an adrenal tumor, or chemotherapeutic agents which block cortisol production. Right, so you might see here Cushing's before and then after surgery, right? So you can see the cheeks here. We also call them chipmunk cheeks, so they're very common. They have chipmunk cheeks. All right, so hyperaldosteronism is etiology and pathogenesis. So primary, we call it Conn syndrome, CONN, right? It's usually due to an aldosterone secreting tumor, right? So in secondarily, you have poor kidney perfusion that's stimulates the renin-angiotensin-aldosterone cascade due to either heart failure, reduced kidney perfusion, or liver cirrhosis. And aldosterone facilitates salt and water retention by the kidneys, resulting potassium excretion. Remember that function, right? So hyperaldosteronism will create hypertension, right? Hypervolemia and hypokalemia, right? So the treatment is spironolactone to increase sodium excretion, and spironolactone is the potassium sparing diuretic, so you'll get rid of the sodium but you will retain the potassium, right? So sodium restriction, so to decrease the hypertension, and then potassium replacement, because remember this one, since it has aldosterone as the main component of its action, it is going to reabsorb too much aldosterone is going to reabsorb sodium. So sodium is the main culprit here. Okay. Pheochromocytoma, I told you we were going to cover these, right? Etiology and pathogenesis includes that where the adrenal medulla is going to secrete catecholamines, norepinephrine and epinephrine, in response to sympathetic nervous system stimulation. So catecholamines increase heart rate, just like as if you were, right, an adrenaline junkie. And if you wanted lots of adrenaline, this is what a pheochromocytoma does, right? So it increases heart rate, blood pressure, and glucose released from the liver, right? It's an adrenal medulla tumor, right? Secreting too much epinephrine and norepinephrine. So hypertension could be persistent or intermittent. It has headache, tachycardia, and diaphoresis. Those are the classic triad. Those three things that you're going to see in a pheochromocytoma. Tremor, nervousness, emotional lability, pallor, fatigue, orthostatic hypotension, right? Hypermetabolic state with fever and weight loss, right? Diagnosis is through abdominal CT or MRI because it is a tumor. So we're looking for a tumor, but now it's in the adrenal medulla instead of in the adrenal cortex, right? So you might sympathetic blocking medications to manage blood pressure, like the beta blockers, right? Or surgical removal of the tumor, right? So surgery is the only curative therapy. Replacement hormone therapy is not necessary. It may reoccur, so it needs an annual follow-up, right? So regulation and actions of parathyroid hormone. So parathyroid gland disorders, right? So the parathyroid glands are located in the upper and lower poles of the thyroid gland on the posterior side, right? And remember that parathyroid hormone is going to reabsorb calcium, right? And so it helps maintain constant levels of calcium throughout the body by also inducing the production of calcitriol. And so that also promotes the absorption of calcium in the intestines, right? And if not, both of those, both parathyroid hormone and calcitriol, can resorb it, can remove the calcium from the bone, right? So calcium basically needs vitamin D to be absorbed, right? Which is what calcitriol is made from. So calcitriol is a derivative of vitamin D. So vitamin D goes and basically incorporates itself in your skin. Remember, it is a fat-soluble vitamin, so it's in the fatty tissue, subcutaneous fatty tissue of your skin, right? Upon being acted on by ultraviolet light, it's going to be converted into cholecalciferol, which then gets converted to calcidiol in your liver and then calcitriol in your kidneys. So calcitriol then absorbs calcium from your intestines. So if you do not have any sunlight or vitamin D, then that means you will not have very good calcium absorption. Right? So calcium levels, right, provide the feedback that regulates parathyroid hormone secretion. So decreasing calcium causes parathyroid release, right? So you release that and then you're going to reabsorb it from the kidneys. Remember, so parathyroid hormone reabsorbs calcium from the kidneys. So we don't want to get rid of it, right, in the urine if we can use it. So parathyroid hormone will get it from there. However, it also stimulates the production of calcitriol, which gets it from your intestines. So you're either going to get it from your intestines from what you eat, or you're going to get it from, don't get rid of it. It's in my filtrate. Before you make urine, let me reabsorb it from there. If it can't get it from either place, it's going to go towards your bone to get it. Because the objective is to have a very clear set point of calcium that is going to be like 9 milligrams per deciliter, micrograms, sorry. And then it is very, very intricately maintained there because calcium is extremely important. Remember, calcium is going to be important for exocytosis. Calcium is important for blood clotting and the clotting cascade. Calcium is important in contractions of the heart muscle and in contractions of the skeletal muscle. So it's extremely, extremely important. All right. So elevated calcium levels lead to suppression of parathyroid hormone release. Right. So again, it acts on bones, intestines, and the renal tubules to increase calcium levels. Right. In the bone, it causes osteoclasts, right, to increase osteoclast activity so that they break down bone. Right. Increases renal calcium absorption and increased phosphate secretion in the kidneys. Serum calcium levels are altered if there are parathyroid disorders, right? So here you can see decreasing calcium levels increases parathyroid secretion, and it is going to promote those things, yes, which we just talked about. So calcitonin is also produced by the thyroid gland, and the parafollicular cells. And those are in the parafollicular cells of the thyroid gland. So those are the cells in between. Remember that I told you that the round things with the colloid in the middle with that pink, right? So the cells in between those circles are your parafollicular cells, or we also call them C cells, right? And then calcitonin is going to be basically working opposite of parathyroid hormone, right? So calcitonin increases bone formation, right? By, right, stimulating osteoblasts and inhibiting osteoclasts. Right, so calcitonin works opposite. Parathyroid hormone increases blood calcium level. Calcitonin decreases blood calcium levels, right? And calcitonin makes bone. So remember, calcitonin is putting bone or calcium into the bone, calcitone into the bone, and then calcitriol ends in OL. It's pulling calcium out. Okay, and so is parathyroid hormone. So those will stimulate osteoclast production. Hyperparathyroidism then, right, causes could be idiopathic, it could be genetic, parathyroid adenoma, hyperplasia of the parathyroid glands, and chronic renal failure, where you see reduced vitamin D. Bone resorption and formation rates are increased, right? Excessive parathyroid gland secretion rarely causes hypercalcemic crisis, right? Malignant cells can release parathyroid hormone-like hormones, so a more frequent cause of hypercalcemic crisis, right? So etiology and pathogenesis: despite elevated calcium levels, parathyroid continues to be secreted during pregnancy, can lead to perinatal and neonatal complications. Newborns with parathyroid hormone production will be suppressed by the maternal hyperglycemia, leading to neonatal hypoglycemia and tetany, right? So it's an electrolyte imbalance, and when the calcium is low, you're going to have overly stimulated muscles, all right? So that's what tetany is. Some drugs such as lithium and thiazides can increase calcium levels. So some of the clinical manifestations of hyperparathyroidism include kidney stones, bone demineralization, polyuria and dehydration, anorexia, nausea, vomiting, constipation, bradycardia, heart block and cardiac arrest, manifestations resulting from high serum calcium levels and bone demineralization. High serum calcium levels decrease neuromuscular excitability. Right, so hyperparathyroidism, right, so serum calcium levels will be low to with a low to normal phosphorus level. So urinary excretion of calcium and phosphorus are elevated, and serum parathyroid levels are elevated. So surgical removal of the parathyroid glands, or hydration to prevent stones, ambulation to maintain bone density, and hypercalcemic crisis causes a rapid volume expansion, right? With 0.9% normal saline and diuretics. Hypoparathyroidism may be idiopathic or autoimmune, secondarily or through thyroid surgery, and may be temporary or permanent. And it can occur usually with the removal of the parathyroid glands. In congenital lack of parathyroid tissue and idiopathic hypoparathyroidism are causes for hypoparathyroidism in children and infants, right? Paresthesias or circumoral numbness in the distal extremities. You have muscle cramping, spasms, fatigue, hyperirritability, anxiety, depression, prolonged QT intervals, increases in intracranial pressure. Severe symptoms, you might see carpal pedal spasms, so you'll see that involves a you'd have to look it up to see what it looks, but if the middle finger is pointed downward, and basically they can't undo that. It's sort of like a cramp. Laryngospasm and seizures, and that could be really bad. The Chotsky or Trousseau's sign for tetany. Remember that was the cheek sign. And then manifestations resulting from low serum calcium levels and increased neuromuscular excitability, right? So hypoparathyroidism increases neuromuscular excitability. Hyperparathyroidism decreases neuromuscular excitability. I'm sorry if that was confusing before, or if I said it backwards. Sorry. Okay. Diagnosis is serum calcium is low and phosphorus is high. You might see antibodies to parathyroid glands if it's an autoimmune mechanism. Right, so treatment is to basically treat the hypocalcemic crisis, so the tetany, laryngospasm, and convulsions. IV calcium and calcitriol, which is an activated form of vitamin D. That's what calcitriol is, right? So long-term treatment is oral calcium supplements with vitamin D. Right, antidiuretic hormone disorders, ADH, which is also called vasopressin, right, is secreted by the posterior pituitary. Right, it regulated by hypothalamic osmoreceptors in response to changes in extracellular osmolality. And so increased serum osmolality stimulates the secretion of ADH. ADH directly is going to have effects on the renal collecting ducts and the distal tubules. Remember, increasing water permeability by increasing the number of aquaporin channels in the cells that are going to concentrate the urine, right? So if antidiuretic hormone is low, we call that a diabetes insipidus. I always call it like the second cousin of diabetes, because diabetes is basically a description of a polyuria, lots of urine, of metabolic nature, right? So of metabolic origin. But the word that follows it is going to tell you whether it's sugar diabetes or whether it's ADH deficiency. Okay, so diabetes mellitus indicates that it's sugar diabetes, and diabetes insipidus means it's ADH deficiency. Right, so we have excessive loss of water in the urine. And that could usually be due to damage in the hypothalamus, and in the ADH producing cells. Could be from brain injury, tumors, or procedures. Some pharmacological agents can also cause ADH to decrease. So means, right, large diuresis of inappropriately dilute urine. Okay, so kind of the same thing that I just said. So central involves hypothalamus or the pituitary gland. Nephrogenic involves the kidneys, right? So you'll see that it could be either, right, that the cells are not responding to the ADH, or it could be that these cells are not producing the ADH. Right, so polyuria, polydipsia is a very common hallmark, right? Low urine specific gravity, nocturia, hypernatremia, dry mucous membranes, poor skin turgor, decreased saliva and sweat production, disorientation, lethargy, seizures, manifestations of cell shrinkage. Right, diagnosis is going to be looking at the urine and seeing that it's extremely dilute, has high osmolality and hypernatremia, along with low serum ADH levels, right? So the dilute urine, high osmolality and hypernatremia in the blood, along with abnormally low serum ADH levels, right? So that's diagnostic of central DI. Right, so water deprivation test with vasopressin. Remember, vasopressin, right, is the medication or the name of the hormone. So you could say ADH or you could say vasopressin, pretty much the same thing, right? So it's central diabetes insipidus. Urine concentration increases. Nephrogenic diabetes insipidus has little or no response to you introducing more of the same thing. Right, so ADH is treated with desmopressin, which is basically the same thing, right? And it home testing of urine specific gravity in case that is in case it needs to be adjusted. So question 3, which of the following laboratory results are consistent with diabetes insipidus? Right, decreased serum osmolality, increased urine osmolality, hypernatremia, and low serum levels of ADH, elevated serum calcium and decreased serum phosphorus, and high serum IGF-1 and elevated serum GH levels. Right, so D, high serum IGF and elevated, that has to do with growth hormone. So that's obviously has nothing to do with diabetes. Elevated serum right? And serum calcium and serum phosphorus, that's going to have to do more with parathyroid hormone than with ADH. Remember, the ADH has nothing to do really with calcium. And so the best answer is hypernatremia and low levels of ADH. And then finally, the syndrome of inappropriate antidiuretic hormone, right? The etiology and pathogenesis is excessive ADH is being produced, and is usually ectopic from a tumor or other location, particularly lung malignancies. So it stimulates the renal tubules to reabsorb water despite decreased blood osmolality. So it can increase blood volume, right? Increasing blood pressure, decreasing urine excretion. Adrenal insufficiency and hypothyroidism can cause increased ADH secretion and hyponatremia. So you can see here some of the pathways in which excessive ADH secretion, right, increased water absorption, right, you have dilutional hyponatremia and increased blood volume, you have a decrease in aldosterone, decrease in sodium reabsorption, increased sodium excretion, so you lead to hyponatremia, right? Same thing over here, increased glomerular filtration rate and increased sodium filtration. Both are going to lead to increased sodium excretion, right? Your syndrome of inappropriate antidiuretic hormone is going to have hyponatremia, high urine osmolality, low serum osmolality, right? Weakness, muscle cramping, postural, blood pressure changes, poor skin turgor, fatigue, anorexia, lethargy. You might see confusion, hemiparesis, seizure, and coma in very severe cases. And you'll see manifestations of cellular swelling, right? So treatment is treat the underlying cause, free water restriction, and then if you have severe symptoms, IV administration of saline with diuretics. Hyponatremia should be treated, right, because to avoid rapid changes in brain cell volume. And hyponatremia, drugs such as lithium may be used to block the effects of ADH. Right, so that was chapter 40. I hope you enjoyed it. It was quite long. Hopefully some of the other chapters this week are going to be a little shorter. They do have less slides, so it's looking hopeful.